everybody joining us this evening. I'm Dr. Cecily Havert. I'm here with Dr. Christy Castillo. We are family medicine, actually internal medicine doctor, and I'm a family medicine doctor at Northern Virginia Family Practice. It's a practice for primary care here in the Northern Virginia area. This evening, we are welcoming with us this evening, we're welcoming Dr. Dara Lee Lewis. She is a cardiologist, actually at in a private practice up in the Boston area. Dr. Lewis graduated from Harvard Medical School in 1992. She trained in internal medicine and cardiovascular disease. She is an instructor in medicine at Harvard Medical School. So currently she teaches medical students. And she also has a very special interest in the management of patients experiencing cardiac symptoms of Lyme disease and POTS. And this evening we are going to be specifically talking about POTS, which is Postural Orthostatic Tachycardia syndrome. It's a little bit of a mouthful, which is why we typically call it POTS. We're very excited to learn more about this evening. I have had the pleasure to get to know Dr. Lewis over the past year in various women in medicine working groups, and was thrilled when she agreed to come on and give us this very, very interesting talk. So without further ado, we'll go ahead and just turn it over to Dr. Lewis. Quickly before we do that, questions, we're going to leave some time for questions at the end. I'm sure that there will be quite a few. We will be not interrupting Dr. Lewis. At the end of the session, we'll go ahead and we'll get to that. So you can put those questions in the chat or in the raise your hand question area. So, okay, now we can go ahead and get started.
All right. Thank you, Cecily and Christy, for inviting me to do this, and for all of you in the audience. So awesome that you are joining. So as Cecily said, I'm Dara Lee Lewis, for those of you who don't know me, and I do see some familiar names in the audience. So welcome to old friends and new. I am going to share my screen. Okay. All right. So I want to just start by saying that every one of you is unique, and those of you who have POTS know that your symptoms may be similar and different to other people who do have. And if you have questions about your own personal condition, please talk to your medical provider. So what I'm going to talk about is general information. What is POTS? How do we classify it? Why does it happen? And how do we treat it? So let me start with a case of Maria. And Maria is a student athlete who came to me a couple of years ago because of symptoms of dizziness and racing heartbeat, especially when she was standing for long periods of time. And this had started when she had COVID. She had sort of the usual COVID, the little fever, cough, lost sense of smell and taste. But the COVID got better after a couple of weeks, but then she never quite felt normal again. So she continued to have this lightheaded feeling when she stood up quickly. Her symptoms were much worse in the summer, right before her period. If she skipped a meal, it was much worse as well. And so the dizziness actually came to the point that she fainted once after taking a hot shower and went to the emergency department. And the doctors there checked her out, said she was fine, and she was just anxious. And she had post-concussion from a concussion she had suffered in soccer years ago. But her symptoms persisted to the point that she stopped running. She was a runner. She had to drop out of college temporarily. And she came to see me after Googling her symptoms, and she said, wonder if this could be POTS. So what is POTS? So it's not, what is POTS not? POTS is postural, as Dr. Havert said, orthostatic tachycardia syndrome. What does that mean? That's a fancy way of saying that when you stand upright, your heart beats really quickly. And importantly, POTS is not a disease, it's a syndrome, which means a bunch of symptoms and findings that cluster together. So the diagnosis is made not by any specific lab test or any particular test that diagnoses it, but by a number of symptoms that people have. Let me move this out of the way. Combined with the heart rate rising by at least 30 beats per minute when you stand. It has to be 40 if you're young. I think it's under 19 years old, has to go by 40, and after that by 30 beats a minute when you stand up, or that the heart rate exceeds 120 beats per minute when you're standing. So for some people, in other words, they start out at 100 laying flat, and then they stand up and goes to 120. So that's necessary to make the diagnosis of POTS. It's also necessary that you don't drop your blood pressure. So this isn't what we call orthostatic hypotension. The blood pressure actually stays stable, but the heart rate rises. And importantly, the symptoms that you would describe would be that whenever you're standing, especially for long periods of time, like say standing at church or temple, standing in the grocery store, you start to feel symptoms. You might feel lightheaded and shaky. So those are the ways that we diagnose POTS. And you can actually, if you're suspecting that you or someone you know might have it, you can technically do this at home. It's not that easy, but you put on, if you have one of those oximeters or a heart rate tracker that measures your heart rate in real time. So you lay flat for a few minutes and you get your heart rate at rest, laying flat, and then you stand up and you measure your heart rate at a minute and then wait 3 minutes and measure it again. Ideally, you're also checking your blood pressure to make sure it's not dropping. But those, I do have patients who, especially during the pandemic, when they weren't coming in the office, would do this at home and report their numbers back to me. Okay, hang on. Okay, oops, did I skip? So the most common symptoms that people report, and Maria reported a lot of these, are specifically, if you stand for a long time, you start to feel like you might faint. You might feel very shaky. You might feel your heart pounding or racing really fast. You might get really tired, and by the end of the day, just feel like you're just out of gas. Flushing happens sometimes. People often get headaches and describe something called brain fog, which is when you just can't get that clarity. It's hard to focus and concentrate. As you can imagine, for a college student or someone who's trying to do something that takes a lot of concentration, this can be really challenging. The classic patient who gets POTS is a woman, but men can get it as well. It usually starts around puberty or adolescence, so often high school or college age. And some people grow out of it. So some people have it, it may never get diagnosed, and then by their 20s or so, it just seems to go away. But for people who don't grow out of it and often go to the emergency department, maybe to their primary care doctor, they're often misdiagnosed, then average 3 to 5 years before they make a diagnosis. It's often mistaken for mental health issues and irritable bowel. So it's not really known. I mean, it's not known what causes POTS. What we see is that it very often follows some type of a major illness. So flu and mono would be probably the most common. Recently, you've probably heard of COVID long hauler syndrome or post-long COVID. POTS is a subset of long COVID. So people who have long COVID sometimes get neurologic problems and cognitive problems, and sometimes they get POTS, and sometimes they get long COVID in the lungs. But the type of COVID that causes POTS is specific to a dysautonomia, which we're going to talk about. Sometimes it follows a major surgery. Sometimes it follows pregnancy. And often the common denominator is it follows a period where someone is at bed rest for some time. And even though that original illness may go away, the POTS may remain. So this is probably the most important diagram I'm going to show you. This is what I call the downward spiral of POTS. And this comes from a great article in the Journal of the American College of Cardiology that I'm going to reference at the end for those of you who want to dive a little deeper. You can see this thing, right? I'm going to move it. I don't know where to, can I make it go away? Hide panel, no, hide. There we go, okay. So a susceptible individual and probably some type of genetic predisposition that we don't know what it is, but this can run in families. So a susceptible individual has some type of event, and that may be an illness or surgery like we talked about. Sometimes it's a concussion. And they start to develop these symptoms. They're tired, it's hard to exercise, it's hard to be upright, they're dizzy. And so as a result, they start to stay at bed more often, they stop exercising. And as a result of this, the heart literally shrinks in size and their blood volume drops. So typically we have about 5 liters of blood circulating in our body at any given time, and that shrinks up a bit. And the muscles, mostly in the legs and the core, start to atrophy and shrink up a bit as well. That leads to another problem, which is that the sympathetic nervous system gets activated. So adrenaline levels or norepinephrine levels increase, and that causes the heart rate to increase. That can cause GI issues, and we're going to talk about that in a moment, can cause headaches. And at the same time, it makes the symptoms worse. So it's even harder now to stay upright and harder to exercise. And as a result, there's less activity and further bed rest. So it's very difficult to break this downward spiral. And often by the time I see patients with POTS, they have dropped off their soccer team, they have dropped out of school, they are spending a lot of time in bed, and it's very hard to then spiral back up. POTS has been broken into 3 subtypes, but I'll tell you in my experience, most people have multiple subtypes, and most people are really a little bit of all 3 of these. But just you may have heard these terms, but the hyperadrenergic subtype means that they're making too much adrenaline, that sympathetic overdrive. People describe that as stuck in fight or flight. They feel tired and wired. So the racing heartbeat is really the prominent symptom for these patients. Then there's a second type called neuropathic, which is where the veins in the legs are so-called weak. They don't respond to the upright position by constricting. So normally when we stand up, we should constrict the veins in our legs to drive the blood up against gravity. And people with a neuropathic subtype, the blood pools down in the legs. These might be the people whose feet turn purplish when they dangle. They don't necessarily get swelling, but there's a little discoloration in the lower body. Then there's a third subtype, which we call volume dysregulation, which is that the kidneys are not, for whatever reason, holding on to salt or sodium. And when they can't hold on to enough salt and they excrete it in the urine, then the body can't retain water. So water follows salt, and without the salt, you can't hang on to water, and people can't regulate their volume. So they often feel super thirsty, drink a lot of water, pee it right out, pee multiple times in the night, and just can't maintain this sort of evolutionary ability to regulate our volume. Again, most people have a little bit of all of these. So let's talk about that term dysautonomia. So POTS is a form of dysautonomia, and dysautonomia means an imbalance between the 2 branches of the autonomic nervous system. And the autonomic nervous system is comprised of the parasympathetic nervous system. That's rest and digest. That's the slow down everything. When you're sleeping, your parasympathetic is active. When you're digesting a meal, your parasympathetic is active, slows down your heart rate, etc. In contrast, the sympathetic division, that's fight or flight, fight, flee, or freeze. It's the activating, getting ready to run from the saber-toothed tiger, getting ready to fight. And as you can see here, virtually every organ in the body is touched by the autonomic nervous system. And the 2 branches, sympathetic and parasympathetic, have opposing effects. So let's break down a little more attention on the sympathetic. So if we blow that up, what does that mean to symptoms? If your pupils dilate, so that, remember again, imagine a cave person back in the day and a saber-toothed tiger breaks into the cave. Your pupils dilate so you can see in the dark. But in modern day, that often happens when it's light out, and it can cause blurry vision and difficulty focusing, can cause headaches. Your saliva glands shut down and you don't make a lot of saliva. Again, if this is fight or flight, evolutionarily, that's great, because you don't want to waste your energy digesting food and doing things like that. You want to just spend all your energy getting ready in case you're going to bleed or run or fight. So in today's world, that means there is no saber-toothed tiger. You're sitting there trying to focus or concentrate, and you have a very dry mouth, accelerating heart rate, racing heartbeat, as we talked about. And then inhibiting the stomach motility, inhibiting the intestinal motility, that means that instead of that normal peristalsis where you eat food, you digest it, it moves through the system and goes out the other end, it sits there. Because again, evolutionarily, I always tell my POTS patients, you would have rocked the cave world, right? Because you have an excellent sympathetic nervous system. You are ready for action. But in today's world, it's working against you because your GI system is shutting down because of a perceived threat. And as a result, you may feel bloated after you eat, food just sits there, you're constipated, and have difficulty emptying your bladder. Again, all that would be great if we were dealing with fight or flight threats, but these aren't physical threats. This is life. This is studying for an exam. This is, trying to get through traffic, etc. So all these symptoms that people describe when their sympathetic nervous system is in overdrive are signs that can be seen in POTS and other types of dysautonomia. So while the two in a normal ideal body work in total balance, so in a normal situation, parasympathetic, sympathetic, they adjust and go like a seesaw up and down all through the day. So you're sleeping, you're more parasympathetic. You're going for a run, you're more sympathetic. And it ought to be always in balance and just checks and balance. But in POTS, the balance is thrown off. And typically it's the sympathetic nervous system that is hyperactive. Okay, so I'm going to switch gears a little and talk about the coexisting syndromes that we often see with POTS. And many of you may have heard some of these terms or have them yourselves, but we often see it with chronic fatigue, something called Ehlers-Danlos syndrome, which is a joint hypermobility. So people who are super flexible. So I have a lot of former gymnasts, dancers who develop POTS and who at the same time when they were younger they were flexible, which was great for gymnastics and dance, but it was probably a sign early on of something called EDS that they may or may not have known they had. But some people say their joints dislocate or they are double jointed. That's often a sign of EDS. Autoimmune conditions can coexist with POTS. Anxiety, and often this is a result of having a chronic undiagnosed disease for many years where your heart's racing. And so people often develop anxiety in conjunction with POTS. Not clear what's the chicken and what's the egg there. GI disorders like irritable bowel, again, for reasons that are really obvious, having a lot of norepinephrine and adrenaline can really affect your digestive system. Fibromyalgia often coexists, migraines and other headaches, and concussions often precede POTS. Again, we don't know the relationship and why these are all there, but we see this so often. So I'm going to give you a little mini science lesson, a biology lesson about gravity. And it's important if you have POTS or someone you love has POTS, if you understand this next little bit, and it might seem a little bit medical, it's really helpful because when you have a bad day, a sick day, a setback, to understand why those symptoms are happening and what you can do to treat them yourself, so empowering to understand that. So I'm going to take a little minute to explain this. When we lie down, so this person laying flat, the red is the blood and the blood pressure, but the blood pressure is the same at your head, at your heart, and at your feet. Now, the minute any of us stand up, this is true if you have POTS or you don't, 30% of our blood pools in our veins below the waist. So the gravity pulls the blood down there, and it doesn't show up as edema or swelling. It's just in the veins that are below the waist. And as a result, less blood is returning up to your heart and less blood is returning to your brain. And this is why people feel dizzy and lightheaded. So what should happen when we stand up? So when we do stand up, what should happen? Well, our heart rate should go up a little bit to raise our blood pressure. Our heart should squeeze a little stronger to raise our blood pressure. And the blood vessels, the veins in our legs should constrict and tighten a little bit. And as a result, even though we're standing upright, our blood pressure should stay stable. And the blood pressure to our brain should stay stable. But in POTS, the several of these things go wrong. So either the leg veins don't constrict or tighten appropriately, or the squeezing function of the heart can't increase any more than it already is. And as a result, the heart rate has to do all the work. The heart rate has to compensate to maintain that blood pressure to your brain. Because again, talking about evolution, maintaining the blood pressure to our brain is the #1 goal of every organ in our body. All our organs, our muscles, our heart, our blood vessels are all evolved to maintain blood pressure to our brain under different challenges. But in POTS, we do maintain that blood pressure, but it's at the expense of a very fast heart rate. So to explain that a little bit, I already told you that blood circulates at about 5 liters in our body, and it's a closed loop, meaning it goes out one end of the heart, goes to the arteries, to the organs, to the capillaries, to the veins, and back again, and keeps going around and around. So you can imagine that if blood is pooling in the veins, less of it is returning. So when we lie flat, our heart rate is normal, and our blood pressure is determined only by three things. So our blood pressure, BP, blood pressure, is determined by how much blood the heart squeezes with each squeeze. So that's determined by how full it is. So if you think about, say, a water balloon and you're filling it with water, if you fill it really big, it can squeeze out a lot of water. But if you have a little water balloon and you're not filling it all the way, even though it might be squeezing nice and strong, not that much is coming out. So remember, we said that in POTS, that heart shrinks down a bit and we don't have enough salt and water to fill it up. So it starts out small. And even though the squeezing function can be normal, and it is usually totally normal in POTS, the heart squeezes nice and strong. It's just starting out what we call underfilled. And so there's just less to come out with each squeeze. So the stroke volume is how much blood you squeeze each time the heart squeezes. Then the heart rate, how fast the heart squeezes. So if we squeeze out more, our blood pressure goes up. If our heart rate goes up, our blood pressure goes up. And SVR stands for systemic vascular resistance. And that's what we talked about, the blood vessels, mostly the ones in the legs and the pelvis are the important ones. Are they constricting in response to that upright position? So when we lay flat, it's no big deal. Because remember, when we lay flat, head, heart, legs, all on the same level. Brain gets plenty of blood. You feel great when you lay flat. My POTS patients love laying flat. It's very hard to get out of bed in the morning for most of them. So flat is the greatest position. But then when you stand up, because the stroke volume isn't enough, because we don't have enough salt and water, so that balloon's underfilled, and because our blood vessels don't squeeze down enough and then don't tighten, the heart rate has to do all the work. So that's where we talked about the heart rate is compensating for the fact that if our blood pressure is staying the same, but this isn't helping and this isn't helping, it's the heart rate that's trying to do all the work to keep the blood going up to our brain. So that's why people with POTS have so much fast heart rate. Their norepinephrine, adrenaline levels are so high because when they're upright, they're trying to maintain their blood pressure. And they're doing a good job, but it's at the expense of this high levels of adrenaline all the time. So people with POTS have levels of adrenaline, if you measured in their bloodstream, like 3 times the normal range. Okay, so how would I test for POTS? So Maria comes into my office and we do something called orthostatic vital signs. So my medical assistant would say, okay, lay down comfortably. She'll leave the room for 5 minutes and come back so that she's equilibrated and check the heart rate and blood pressure when she's laying flat. Then we have her stand up, wait a minute and check the heart rate and blood pressure, and then keep standing. And some people can't keep standing for 3 minutes. They have to sit down, which tells me a lot too. But if you can keep standing for 3 minutes, we check the heart rate and blood pressure again. And to make the diagnosis of POTS, you'll remember the blood pressure doesn't drop. The blood pressure stays the same, but the heart rate goes up by 30 beats. And we always ask people how they feel, and they often, if the heart rate's going up, they're often feeling kind of dizzy. Tilt table test, you may have, many of you may have had this or heard of this. It's a test that's done in a special laboratory, usually in a hospital, where they take a patient and strap you to a bed and then passively tilt you upright. And they're measuring heart rate and blood pressure while you do that. I don't personally believe that tilt tables add much to my diagnosis. And I think they're extremely uncomfortable for a lot of people. They're also just not that accurate. So we see false positive results where people who really don't have POTS have a positive tilt table because it's a passive tilt. Your leg muscles aren't engaged. Often people are fasting, so their blood pressure might drop a bit when they get tilted up, and their heart rate may go up really fast. So even people who don't have POTS can sometimes have a positive finding, and false negatives. So even people who do have POTS may have a negative tilt table, because again, it's not a natural situation. It's usually fasting overnight. They often make people stop whatever meds they're on that might have been helping. You're not having your salt if you're already somebody who's on salt. And so it's just not, to me, a useful test, not worth the trouble and discomfort. A lot of people get autonomic testing, which neurologists do. So I don't in Boston, we usually have neurologists and cardiologists co-manage patients with POTS, and they do a fancy kind of autonomic testing where they do a tilt table. They also measure cerebral blood flow, so the blood flow to the brain versus, blood pressure measured in the arm. And then they often do skin biopsies and look for something called small fiber neuropathy and also sweat gland density. So they measure parasympathetic tests, sympathetic tests, and a whole bunch of things. In my office, I just do the orthostatic vital signs, but I often send people for autonomic testing. Okay, so let's say the diagnosis is made of POTS. With Maria, she was absolutely right. She had Googled and found POTS, and she absolutely had POTS. So treatment always starts with lifestyle changes. And for most people, probably at least 60, 70% of people, that's all you need is the lifestyle changes, and you don't ever need to get to the meds. There are people where this doesn't fix it enough and we have to go to meds, which we'll talk about, but lifestyle for everybody, absolutely important. And if you think about a stool with 3 legs, each leg is equally important. And to have 1 or 2 of these and not the third, the stool's going to fall over. So sodium, compression, and exercise are the 3 cornerstones of treating POTS by lifestyle. So sodium is basically salt, compression is compression garments, and exercise there's very gradual exercise programs that start out when you're recumbent, like a recumbent bike or laying on your back doing bicycles, and then moving to upright. So depending on how severe someone's POTS is, sometimes I just start with sodium and compression and I don't add the exercise until they're ready. But all 3 of those eventually have to happen for someone to get better. So why salt? Well, remember, water follows salt. So if you have enough salt in your system, then you will retain the water and hang on to the water. When salt isn't enough, we use a medicine sometimes called Florinef or fludrocortisone, which tells the kidneys to hang on to salt. So salt, and it's more than just saying like add salt to your food. We usually aim for 4 to 8 grams of sodium a day, which is a lot. So 2.3 grams of sodium is what's in a teaspoon of table salt. So if you imagine, like in the morning, you take 2 teaspoons of table salt and put it in a dish and try to eat that in the course of a day, that's a lot. So some people can do it. They put salt in water and drink it, or they like dill pickles, which have a lot of sodium, or depending on what foods you eat. But a lot of people have to take salt tablets or salt drinks. Compression comes in many forms. Again, you can have compression socks, knee-high socks, or like bike short type compression that compress the pelvic blood vessels. You can have leggings, you can have thigh-high stockings, whatever. Compression helps push the blood into the bigger, larger, deeper veins and helps keep it in circulation. So again, we could talk an hour about compression, and there's a lot of different types of compression out there. Some people love it, some people hate it. People have really strong feelings about compression, but the more surface area of your body that you cover, the better. And the tighter the compression, so they come in like 10 to 20 millimeters mercury, 30 to 40 millimeters mercury. The tighter the compression, the higher number, the better. So if you have really bad POTS, you may need to find, leggings that are 30 to 40 millimeters mercury. If you have really mild POTS, you might just get those footless calf sleeves that are 10 to 20 millimeters mercury, and that might be enough for you. But if it helps to do a little, try more, try more, try more. That's true of salt, that's true of compression. When the compression itself isn't enough, we use a medicine called midodrine, and that is a medicine that tells those blood vessels to constrict. So backup, again, lifestyle, salt and fluid with Florinef as a backup, and compression with midodrine as a backup. And then exercise helps to reverse that downward spiral by improving our heart function, our muscles, and increasing blood volume and helping the heart to grow back to a normal size. Again, if you start exercise too much too soon, when your body's not ready for it, it'll actually make you feel much worse. So it has to be done very carefully. All right. And then the medications that we sometimes use to supplement the lifestyle would be if somebody really is a hyperadrenergic type POTS and that racing heart rate is really bothering them. Sometimes we use a little bit of a beta blocker, such as atenolol, or a medicine called Corlanor or avabradine, which also slows the heart rate down. And sometimes our neurologists will prescribe medicine if someone has a lot of dysautonomia, including especially constipation. And Mestinon is a medicine that can really help with that sometimes, and also intravenous immune globulin, or IVIG. Though I don't prescribe those, the neurologists tend to do that, and sometimes people get a good response. So the other piece of treatment is to really anticipate what your triggers are and to be prepared, because if I had a little lab rat and I could totally regulate everything that rat ate and how much exercise they got and how much sleep they got and their hormone levels and the humidity in the air, every day would be the same and they'd probably be fine. But none of us live a life like that, especially at the age group that POTS tends to appear. It's often in high school or college or early career, when people don't really have a routine. It's often really challenging to get up at the same time every day, to eat the same thing every day, to even take medications, to put on compression. So it's a difficult challenge, but the more you know your triggers and the more you understand that physiology, the more you can manage the day-to-day changes in your symptoms. So avoiding skipping meals. And again, sometimes that means that for students, you got to keep your backpack full of snacks because you don't always have time to sit down and have a real meal. When you do have a meal, generally speaking, high protein is going to be tolerated better. High carbohydrate meals can lead to a release of serotonin, which can open up and dilate those blood vessels and can drop the blood pressure. So a meal that's just carbohydrates will often make you feel worse. Heat is a problem for a lot of people, especially a hot tub, a hot bath, a hot shower. So most POTS patients, by the time they meet me, have already figured that out and they take lukewarm showers. That may sound familiar to you. Any situation where you're standing in line and you can't sit down can also be a real challenge for people with POTS. So, when you can have somebody pick up something for you at Target and don't stand in line, or keep your eye out for a chair or a place that you could sit down. When in doubt, just sit down on the ground if you have to, because standing and ignoring your body signals that you are lightheaded and getting worse and more tachycardic, you may faint. So you got to sit down if you feel like you're going to faint. Trying to stay cool, exercising indoors in the summer where there's air conditioning is really important. They make cooling scarves and cooling vests that you can put in the fridge or the freezer or rinse under cold water and wear them around your core. That can help too. For a lot of women who have POTS, they recognize that right before their period, that's when their symptoms get a lot worse. So for people who have regular periods, which is definitely not everybody, they may increase their salt by an extra gram starting 3 days before their period, things like that. And then having a sick day plan, which is, let's suppose you get the flu and you're not able to keep anything down for a couple of days, what are you going to do? So you're going to want to go back to what you know, and as much as you can, keep the salt in, as much as you can, wear that compression when you're sick, and you may have to back off on exercise. So back to Maria, so a super success story. So she was diagnosed with POTS and she didn't want to start medications unless necessary. So I agreed with that. So we built up to 4 grams of sodium. We started with 2, that helped a little, went up to 3, that helped a little more, went to 4, great, 5 didn't help, went back to 4. She started wearing knee-high compression socks. She found some that she thought didn't look like her grandma's, and she started wearing them in leggings. That really helped. She started a gradual walking program and built up to where she's actually jogging again. And she's back in college. So that was a fairly long road. So 12 months, but she's pretty much back to where she had been. So this is a nice graphic, again, from that Journal of American College of Cardiology article I was telling you about, that we give our patients. So from up in the left-hand corner here, avoiding these situations that make you worse. For a lot of people, alcohol is also a vasodilator. It dilates those blood vessels and can make POTS worse. So a lot of POTS patients don't drink much for that reason. They just don't feel good. Plenty of salt. The water, it is possible to drink too much water. You have to balance the salt in the water, because if you drink too much water, you actually end up being counterproductive, diluting your blood and then peeing it out. So I usually tell people to add the salt and then follow their thirst. So typically the thirst mechanism, especially in young people, is very accurate, and it'll tell you when your body needs more water. So add the salt, follow it with the water when you're thirsty. A lot of people elevate the head of their bed, because what that does is it sort of gets you used to having your head above your heart and above your legs. And then getting up in the morning isn't quite such a dramatic shift. So that getting up in the morning from totally flat to totally upright can be really challenging for people, as we talked about. So sleeping at a little bit of an elevation gradually. So usually start with 2 inches for a couple of weeks, then go to 4 inches for a couple of weeks, and then go to 6, can help reduce that morning shock. The compression garments, including abdominal binders, and these full-length hose, or if all you can handle is the knee-high, whatever, again, the more surface area and the more depth of compression, the better. And then if you do find yourself standing in line and feeling symptomatic, you can do these, what we call counter maneuvers, where you can cross your legs, you can clench your pelvic muscles, you can squat down. All those things will help. It even helps to, believe it or not, just cough really briskly will give a little blood to your brain. So in a pinch, if you can't sit down, try those clenching maneuvers. And as far as this, the one thing I disagree with on this page is this. I do believe in drinking water before you get out of bed in the morning. What I tell people who have a really hard time getting up in the morning is to keep a big glass of water by your bed, but also keep, if it's a salt tablet or a salt drink, so have salt water before you get up in the morning, and put on your compression before you even get out of bed. Because if you challenge your body so much in the morning by going upright, and your norepinephrine, adrenaline levels are shooting up in the morning, it's going to be a long day. And I pretty much guarantee that by the end of the day, you're going to be totally exhausted. So you want to make your morning as good as it can be. So try to give yourself at least 20 minutes or so with salt water in the morning. If you're someone who takes meds, I have people leave it by their bedside and take the meds first thing in the morning and let those kick in before they stand up. But as much as you can do before you stand up, because standing up, believe it or not, is really, really stressful on your body. And then when we talk about exercise, these strategies that I said about recumbent bicycle, but also swimming is a fabulous exercise, and rowing machines are just perfect for people with POTS, because you can start to get that volume going without actually standing upright. Once you get that going, then you can exercise and be upright at the same time. But until you can do those two things at the same time, exercising flat is really good. I also tell people that half an hour to an hour before exercise to take an extra 500 milligrams of sodium, so that you tank up your volume before you start exercising, because exercise diverts blood to your legs, and you don't want to divert blood to your legs at the expense of your brain, because you want to have enough to go around. So if you get extra salt and water, put on your compression, wait half an hour, and then exercise, you're setting yourself up for success, because you don't want to set yourself up for failure. It's hard enough. Okay. And for people who want to learn more, there's a great book written by a mom of 2 kids with POTS and a doctor, and it's called Together We Stand by Jody Epstein-Rum. It's a really nice book. It has some physiology and background about what POTS is, and then it has sort of testimonial and personal story, and then it has recipes and stuff like that. It also has a really nice chapter on accommodations, and I didn't mention this, but Maria went back to college with accommodations. And what that means is there's a whole set of accommodations for people with POTS, which some of you I know on this audience have, and a doctor needs to write this, requesting them for you. But it would be something like, I need to have a shuttle bus to take me from my apartment to my classes, so I don't have to walk carrying a heavy backpack for half a mile to get to class. I need to have first choice of classes, that time of day that work for me. So for a lot of people with POTS, the morning is super challenging and they want to start their classes, 11 a.m. or later, and have air conditioning in my apartment and things like that. So there's accommodations to make it easier for you to do the actual work of being in college without having to do the work of surviving day to day with POTS and all the challenges that come with being in a college campus. So this book has a lot of those in there and a lot of examples of what accommodations look like. And then for those of you who might want to look at the actual article from the Journal of American College of Cardiology, it's actually great. And that vicious cycle downward spiral is from this, and also that last diagram. So those are really helpful. And I want to end with a quote from one of my favorite poets, Maya Angelou. You may encounter many defeats, but you must not be defeated. In fact, it may be necessary to encounter the defeats so you can know who you are, what you can rise from, how you can still come out of it. Really applicable to all of you with POTS. You've been facing a lot of defeats and you can still come out of it. So thank you so much. I'm going to stop sharing.
Great. That was fantastic, Dara. I absolutely, loved hearing that. I learned actually quite a bit from this talk. I think we do have a couple of questions that we can start with. Christy, do you want to pull up some of the questions?
Yeah. So we have actually a POTS patient who was diagnosed quite a while ago, back when they would call it mitral valve prolapse syndrome, and she thanks you so much for being here. She is wondering if you can speak to the link between POTS and multiple systems atrophy. She's wondering if they're both under the dysautonomia umbrella or if there's a correlation between them. Her cousin just passed away from multiple systems atrophy and started with an initial diagnosis of POTS only.
Okay. I don't know a lot about multiple systems atrophy, but I think what's going on here is that when people stand up, and this actually, I see the second question is, can POTS be mistaken for neurally mediated hypotension? So there's a big difference between orthostatic hypotension, which is that when you stand up, your blood pressure drops, and POTS. And my guess is that this person, her cousin, I'm so sorry, it sounds very tragic, but I don't think this person had POTS. I think that they were probably misdiagnosed with POTS and really had multiple systems atrophy. So there are a few causes of orthostatic hypotension. And for example, people with advanced diabetes, people with Parkinson's disease, sometimes just very elderly people, when they go from laying down to standing up, their blood pressure drops for the reason that's totally different than the POTS reason. It's that we have little sensors in our carotids and in our heart that detect a drop in blood pressure. That's how our body knows we're upright. So for everybody, we stand up and unbeknownst to us, subconsciously, our body detects a drop in blood pressure and sends a signal to the brain and the adrenal glands to make more adrenaline, norepinephrine, and get the blood pressure up. And it happens just a split second for most of us, to the point that we stand up and we go on our business, and our blood pressure and our heart rate and our stroke volume and everything stay fine. But people who stand up and that message that, whoa, the blood pressure dropped, that message doesn't get to the brain in the first place. So say someone, I just saw someone today who had really severe Parkinson's disease, and she stands up and she feels really dizzy, but her heart rate doesn't race because her vessels don't constrict, because she doesn't actually, her brain doesn't register that she is upright. So it's just simply that pooling without the compensation of any sort. The heart rate's not compensating, the blood vessels aren't constricting, the squeezing isn't increasing. And that's a totally different situation. We do actually treat some of that with fluoronephrine, midodrine more commonly, but it's not the same. So there can be misdiagnoses of POTS and dysautonomia and neurally mediated hypertension. They can all overlap in terms of symptoms, because all these people would stand up and feel dizzy and sometimes faint. But that's why you have to do those vital signs. So the difference is that in POTS, the blood pressure doesn't drop, but the heart rate goes up. And in these severe dysautonomias where they stand up, the heart rate doesn't go up and the blood pressure drops.
That's really helpful. And I know that there's a lot of crossover, and as primary care doctors, a lot of times, we are kind of on the kind of the entry level of, patients coming in with their symptoms and everything. And, it can be tricky to try to, tease this out, tease that out. But I think that, the orthostatic blood pressures that you were talking about can be really, really helpful. But, one thing as a primary care doctor that I struggle with is that there aren't, you do get patients that maybe you suspect it's POTS, or maybe there's, it's just sort of hard to kind of get a handle on exactly what's going on. And there really aren't too many people in this area, other specialists in the area that treat POTS, whether they be cardiologists, whether they be neurologists. So, as a primary care doctor, we're kind of trying to navigate the system a little bit. Do you have any, tips or recommendations as just being in this position as a primary care doctor, how we can help these patients out if we can't find a good doctor to send them to?
It's so challenging. It's so challenging even in Boston, which has more doctors than anywhere. And I think sometimes there's pediatric cardiologists often treat POTS, and they often are really comfortable with POTS because this often appears in young teenagehood. So sometimes leaning on your pediatric colleagues can be useful. It's when they age out of the pediatric cardiologist that can be tricky. You can always call me. And I actually love to talk to primary care doctors and other cardiologists. A lot of my colleague cardiologists call me just for tricky cases. There aren't a ton of great resources. That article I put in there from Journal of American College of Cardiology is actually a beautiful review, and it has a lot of the medications in more detail. Like that would be the one sort of Bible of POTS that I think a primary care doctor could use and get a lot of useful information out of. But it's tricky, isn't it? It's tricky when you don't have people. I have patients who fly all over the country to go to these POTS specialists. There's somebody in Ohio, and people hang up a shingle and become a POTS specialist. And honestly, like, I don't know. I think they sometimes come up with different ideas and creative ways to think outside the box, and sometimes those are really helpful, and sometimes it's a lot of expense and flying around and not hearing anything all that different. But patience, trial and error, and empowering and educating your patients so that they do most of it. Because one thing I've learned is our patients know their bodies better than we do, for sure, and they feel the symptoms coming on before we do. They make a lot of the connections and see the triggers. So most of what I've learned from my patients, and a lot of what my patients have learned, they've learned from each other. So, there's a POTS Facebook support group that some patients find helpful. Some patients find that really unhelpful because the people that tend to post on there tend to have really severe POTS and other things going on. So I've had patients say, like, they're never going to look at it again because they came off that feeling like they're going to, die a terrible death with POTS, which really POTS, the good news is it's not life-threatening. Mm-hmm. So sorry, I don't have a great answer for you.
No, I think that's fantastic. And I think educating and empowering our patients is, something as well as doctors in general, but especially primary care doctors, that we really try to do. So that's a good reminder.
Yes.
Christy, any more questions in the queue?
Yeah, we have an 82-year-old female who's wondering if she's too old to have POTS.
No, you're never too old to have POTS. So if you're 82, I would definitely think about other things that can happen in older people, like this neurally mediated hypotension. So you definitely want to check that blood pressure standing up. It would be an unusual time to have first onset POTS, but some people, so about 50% of people who get POTS grow out of it, and it's not an issue by the time they hit their older years. But about 50% of people have it all their life. And some people have had it for decades and just never knew what it was, why they hated hot baths, and, why they faint when they go to the beach. So it's go to your doctor and get those orthostatics checked and think about, when did this start, and did it follow any particular illness, and do compression stockings make you feel better, and try a little bit of salt. So again, a lot of patients figure this out too, and without even seeing a doctor, they find that they crave salty snacks and they eat them, and that makes them feel better. Or they, most people don't figure out the compression until someone tells them, because people don't usually like that. But it's definitely possible to have POTS when you're 82. Not common, but possible. And, that's talking about the long COVID. In the last couple of years, I've had 2 sort of middle-aged men with POTS from long COVID. And that's it. Again, it's unusual to be a middle-aged man and have POTS, but we do see it in association with long COVID.
Do you have a kind of off the top of your head, an idea of what percentage of your POTS patients, you're able to kind of line down a possible trigger, a source for it? Like, was it viral? Was it a surgery? What percentage are you able to kind of trickle that down to?
Yeah, it's so interesting. I'd say at least 70%, but for a good percentage of those, there are a lot of possible candidates. So a lot of student athletes get POTS and have had multiple concussions. So it's kind of hard to say, like, when did those headaches start? You know, my first concussion was in 4th grade. And then, so I'd say that sometimes it's really obvious, like mono. I'd say mono is a huge one. They never got over the mono or the flu. But for a lot of people, there were sort of a few triggers throughout their adolescence. And things just gradually got worse. Some people got worse, I hate to say it, after the COVID vaccine, or after COVID. So reason to get your vaccine. And I see, as you mentioned earlier on, people who had Lyme disease. So acute Lyme, if it's treated early with antibiotics, typically you 100% get over it. But often Lyme is not diagnosed at the time that it occurs. And a lot of people have, or they get treated and they don't get better. So this post-treatment chronic Lyme disease, which is a bit nebulous also and a little bit controversial, but I'd say a fair amount of my patients have POTS that seem to stem from that.
Along the lines of triggers, I collaborate a lot with mental health professionals, and especially mental health professionals that treat a lot of trauma, childhood trauma or trauma otherwise. And we've had conversations where it seems like there's a really strong correlation between trauma and having POTS. And I'm not sure if that's just a correlation or collaborate or or causation, or can you speak to that at all? Is that anything you either know anything about or just even observed yourself?
I'm so glad you brought that up. That is actually a huge one. I have many patients who had childhood trauma, and sometimes just unbelievable childhood trauma. And the way that I look at that is, and they tend to have the worst dysautonomia. I think their autonomic nervous systems never developed normally to get disrupted. They just never were in parasympathetic mode. So yeah. I think if you grow up in a situation where you don't know the difference between this is calm, this is when we rest, and this is when we're good, and this is now it's time to be active and exercise. Like when kids grow up and it's chaos and it's unpredictable and it's potentially dangerous, I think there's just constantly this chaos in your autonomic nervous system. So for people like that, it's really, 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 really important to get at that root cause. And I don't think people get better till they do some treatment for that underlying trauma that just sits under the surface and bubbles even decades after the trauma is gone. So PTSD, childhood abuse, eating disorders, all of those things are actually quite common in POTS patients.
And that makes a lot of sense, when you think about, constantly not feeling safe and being in fight or flight constantly. So that's very helpful.
Yes, and there's something that this neural retraining, where it takes many different forms, but trying to train back your parasympathetic system and exercise the parasympathetic system. For all of us, it's really important, but for patients like that, it's super important. And some of it is as simple as those really deep breathing exercises. And then there's you may have heard of the EMDR and all the sort of formal retraining where you retrain your brain. I've had a couple of patients have really good luck with that, but having a really good therapist or a really good person to work with on that is super important.
Great. Thank you. Thank you for that. We've got a few more minutes left. Christy, anything else?
Last one is, if somebody who was diagnosed at, say, in their teens or 20s, do they have a potential to grow out kind of later in life, or is it mostly they will always have POTS, but maybe they feel better because they're managing it better?
Yeah, so that's a great question. I think that there are a lot of people who have very mild POTS. So POTS definitely occurs on a spectrum of severity. And there are people who have really mild POTS, and it may only flare up when they are really dehydrated for some reason, or they're under really a lot of stress. And so for people like that, I'd say that, it's hard to say, like, do 50% of people grow out of it entirely? I think those 50% probably always have a vulnerability to not having enough salt. And salt, like Disney World. So I have a bunch of young moms who've taken their kids to Disney World in the summer, or Disney, whatever the one is in Florida, and end up in the, urgent care there clinic. And I was going to say I should set up a POTS clinic at Disney, because standing in line, it's very hot, you're not eating or drinking, and you're, running after your kids. That's like the classic setup. So I think a lot of people grow out of the worst of it, but they always still need to be mindful. And I just tell those people, keep your salt packs in your purse and have your plan, and stay out of the sun, and let someone else take the kids for a while, and you go sit in a nice, cool, air conditioned room. Because I think, some people just say like, oh yeah, I've always loved salt and I always add salt to my pizza, and now you're telling me it's because I have POTS. That is probably somebody who all their life, as long as they have enough salt around, they're just going to be fine, and they're managing it. And then there's other people who have to do the salt, and they have to have their compression, and they have to stay out of the heat, or else they're going to not be fine, but they can manage it too. So are you ever really cured of POTS? Maybe not, but you can definitely live a long, healthy, vibrant life. I had 2 of my patients graduate from college this year, which was super exciting. People get back in school, that get back on their jobs. For the most part, this is a really manageable syndrome.
That's awesome. So rewarding for you too, to kind of see that, right? Having them come back and get their life back, really. So thank you so much. This has been an amazing conversation. Like Dr. Havert said, I've personally learned so much. I'm sure our audience has. We're so appreciative of you being here with us.
Thank you so much. It was really, really fun. And I hope people learned, and thank you for spending an hour and a beautiful evening here. So
absolutely. Thank you so much, Dara. I will add that Dara did mention a few different resources. Dara, if we could get the links to the journal that you recommended, and also maybe even a link to the Facebook group if people are interested in that. Once we, the recording of the show will be available probably in the next couple of days, and we'll link all of that information to that. And then I will just add that in another month, we'll have our next town hall meeting, and we'll be switching gears a little bit, but switching to the gut. Dr. Tim Doherty will be talking about reflux. I think that's going to be November the 16th at 7 p.m. Right before Thanksgiving. So we'll just, learn how to treat all of our Thanksgiving-induced reflux at that next town hall. So, but thank you so much, everyone. We will see you next time.
Thank you. Have a good evening, everyone.